Welcome everyone to Chapter 25. This is caring for clients with disorders of coronary and peripheral blood vessels. So the learning objectives for Chapter 25 are as follows. Distinguish between arterial sclerosis and atherosclerosis. List the risk factors associated with coronary artery disease, also known as CAD, and discuss which can be modified. You should describe the symptoms, diagnosis, treatment, and nursing management of coronary artery disease. Discuss the symptoms, diagnosis, treatment, and nursing management of myocardial infarction, also known as MI or a heart attack. Discuss the symptoms, diagnosis, treatment, and nursing management of peripheral vascular disorders. Discuss the symptoms, diagnosis, and treatment of varicose veins. Describe nursing management of clients undergoing surgery for varicose veins. And discuss the symptoms, diagnosis, treatment, and nursing management of clients with an aortic aneurysm. Here are the words that you need to know for Chapter 25. You can find this in the chapter right below the learning objectives that we just discussed. So whenever we are talking about someone who's got a heart disorder, who's having a heart attack or some type of cardiac issue, time is muscle. When you review your PowerPoint, if you would, select the link provided here that says CPR in real time. It's just a brief video that shows a dispatcher for a air evac system who has a heart attack while he is at work, and it shows his coworkers giving him CPR. It's an excellent video, so take a few minutes and watch it. So arterial sclerosis is the loss of elasticity or hardening of the arteries that accompanies the aging process. So this occurs over time and as we age. Causes can be calcium, which is deposited in the cytoplasm. The calcium causes the arteries to lose that elastic movement that they should have. When the left ventricle contracts, the rigid arterial vessels fail to stretch. This results in reduced volume of oxygenated blood delivered to the organs such as the myocardium, brain, kidneys, and extremities. So once again, this would be your decreased cardiac output, which causes a decrease in nutrients going to those vital organs. So arteriosclerosis is a complex condition that produces structural changes to the arteries, usually associated with the loss of elasticity. Atherosclerosis is a specific type and most common cause of arteriosclerosis. Now, both disorders affect the ability of the vessels to deliver blood and are considered occlusive disorders, but the causes are different. Here, with atherosclerosis, you have fatty buildup in those arteries, plaque, fatty lipids, cholesterol. These are factors that cause that occlusiveness for the atherosclerosis. Risk factors can be mechanisms of fat formation and metabolism, which occur individually, obesity, and inflammatory responses. So here there's a video link that kind of goes into detail with atherosclerosis. If you would just click that on as you review your PowerPoint and check out the video. Increases in diastolic and systolic blood pressures are associated with an increased incidence of atherosclerosis, often an inherited factor. Elevation of blood pressure results when the vessels cannot relax, and that impairs the ability of the artery to dilate. Hyperlipidemia, diabetes, and obesity are all risk factors of atherosclerosis, but they do not result from the disorder, meaning that they are not the end result of the disorder. They may be risk factors. The classic symptom of CAD, or coronary artery disease, is chest pain or angina, or discomfort during activity or stress. Such pain or discomfort typically is manifest as sudden pain or pressure that may be centered over the heart, precordial area, or under the sternum, which is the substernal area. Occlusive disorders of the coronary blood vessels are the closing of a coronary artery, which reduces or totally interrupts the blood supply to the distal muscle area of the heart. Coronary artery disease precedes coronary occlusion. If left untreated, this can lead to your MI. Symptoms usually do not occur until there is at least 60% of the arterial lumen that's occluded. So once you get to around that 60% mark, the patient will begin to have symptoms. So our patho consists of arterial sclerosis and atherosclerosis, which both, as we discussed, impair that blood flow to the myocardium. Causes can be an inherited factor, men more than women, diabetics, increased lipid levels, genetic predisposition, and hypertension. You have some behavior risk factors that can lead to that CAD, such as smoking, a sedentary lifestyle, obesity, that aggressive or angry personality, that angry behavior, and a high fat diet. So, regular exercise, managing stress, and checking those cholesterol levels are just ways to modify or take control of that coronary artery disease. So here on the pictures on the right just show you some different areas or different types of feelings that the patient may have when they're complaining of their chest pain when they come in. But most of the time, your patient is asymptomatic or they just have a vague complaint of fatigue. That chest pain, also known as angina, can radiate from the chest to the shoulders, arm, especially on the left side. It can be in the jaw area, up into the neck area, and even in the teeth. You have atypical symptoms such as nausea, fatigue, and dizziness. You may see that as well when the patients come in and you are doing that assessment, that cardiac workup. So, how are we going to go about diagnosing the CAD or the coronary artery disease? Well, the diagnostics we're going to do are going to be like your lipid profile studies. We're going to look at that cholesterol level. We're going to look at that LDL, which is your bad fat. We're going to look at that HDL, which is your good fat. We're going to look at those triglycerides. We may do some other diagnostics like an exercise stress test, cardiac catheterization. We're going to look and see if we see any plaque in there. We're going to look at that EKG and ECG to see if we see any changes, maybe an ST elevation that showed that you're having an MI. maybe some thallium stress tests. These are just some of the diagnostic tools we would use in CAD. So, with a person with CAD, the medical management is going to consist of weight loss, stress management, getting those blood glucose levels under control. We may even have some drug therapy such as nitrates, beta blockers, calcium channel blockers, ACE inhibitors, diuretics, cholesterol medications. We may encourage some vitamins B6 and B12. So know that when a patient's taking their nitrates that they can develop a tolerance to that drug over time. So in order to prevent that tolerance from occurring and to maintain the benefit of the nitrate medication, if the client is wearing a transdermal patch and nitroglycerin patch, we have them take that nitroglycerin patch off at bedtime. So when they go to bed at night, they'll take that patch off, discard it, and the next morning they will get up and put a brand new patch on. If the client is taking beta blockers, we want to educate the client, let them know that they're taking those beta blockers to decrease the workload of the heart, and that helps the heart to pump more effectively. We may have to do some surgical management, such as a PTCA, which is your percutaneous transluminal coronary angioplasty, or a balloon angioplasty. A coronary stent may have to be placed. We also may remove some of those fat or plaque buildup. The patient may have to have a CABG, which is a coronary artery bypass graft surgery. Or you may have to do some transmyocardial revascularization. That's for patients with chest pain that don't respond to medication and those who are not candidates for a CABG or your bypass surgery. But know that if your patient has a PTCA, that you need to monitor the patient for any abrupt closure of that coronary artery. So if you do that procedure afterwards, the stent may fail, and if it fails, you're going to have an abrupt closure of that artery, and the patient's going to have some chest pain immediately following that. You also have to monitor for bleeding at the insertion site. So the most common areas where they do the PTCA is going to be the radial artery, the brachial artery, and the femoral artery. So you want to monitor those sites for any bleeding that can occur. Because bleeding can occur, especially if in a femoral area, the patient can bleed up into the retroperitoneal area and develop huge hematomas at the stomach area or down into the thigh. They can also bleed all the way up into their shoulder if they have a brachial area. If it's done in the radial area, they can bleed all the way from the radial area all the way up into their shoulder area as a result too. Know that dye is given during this procedure, so you want to monitor the patient for any potential kidney area injury. So you're going to look at their BUN and creatinine levels and make sure that they're avoiding without any problem. Make sure that their urine output is adequate. And know that you always need to give some emotional support to your clients whenever they're going to have some type of procedure done. Know that chest pain is scary. They may have a feeling of impending doom, or they just may be totally afraid of having the procedure done because they don't know what the outcome's going to be. And they know that that may be life-changing. So make sure that you get the client to share any feelings that they may have and work on relieving that stress and reducing that emotional distress that your client may be feeling when they're going to have some type of surgical management done. As the nursing part of our management, you need to assess the characteristics of the chest pain and administer those prescribed drugs. They dilate the coronary arteries or they reduce the workload of the heart so it will pump more effectively. You should also encourage rest, especially if it's a brand new diagnosis and they've just come into the hospital. You want them to rest a little bit. They can still ambulate around the room, get up and go to the bathroom, and maybe take some short walks, but they do need some rest in between. Be sure to administer oxygen, and that improves the oxygen supply to the heart muscle. Because if you don't have adequate oxygen to that heart muscle, it's going to impair that flow. Be sure to educate the client to reduce those modifiable CAD risks that we talked about, such as smoking cessation, a sedentary lifestyle, obesity. When you're preparing for the client for the diagnostic tests and treatment procedures, make sure you give them good explanations and that they can relate to, and just educate them properly. When assessing the pain, it is associated with activity or stress. You want to ask if it's a sudden pain. Is it a pressure type? Where is it located over the heart? Is it precordial? Is it substernal? Is the pain radiating to the shoulder, arms, left side, jaw, neck? You want to really do a good, thorough pain assessment whenever you are looking at gathering that information on that patient with the CAD. So angina is grouped into three categories. As you see here, we have stable angina, unstable angina, and variant angina. Stable angina occurs during exercise or stress. It is relieved with rest and nitroglycerin, and usually subsides within 5 to 10 minutes. Your unstable angina can occur during exercise or rest. So you could be sitting there watching TV and have an episode of unstable angina. With this angina, however, it has an increase in occurrence. So you may have one every day, or you may have two episodes of unstable angina every day, or you may have one a week. But the frequency varies, but it increases in occurrences. The severity of it also increases. So instead of it being a 5 today, it may be a 10 next time. So the pain, it just gets worse over time. And as the duration also increases. So rather than take one nitroglycerin with relief, you may have to take up as many as 3 before you get relief from your unstable angina. And yes, you're going to use nitroglycerin to treat your unstable angina. With your variant angina, that's your coronary arterial spasm. And this occurs during rest. So this could wake a patient up in the middle of the night. They could have their variant angina. It occurred while they were asleep, while they were at rest. Once again, they're going to treat it with nitroglycerin. I start out with taking one. 5 minutes later, take a second one. And 5 minutes later, take a third one. If they don't have any relief during any periods of any of these types of angina, whether it's stable, unstable, or variant, if the patient does not have any relief from their nitroglycerin, they need to call 911, call their provider, and get to a hospital immediately. Nitroglycerin is given sublingual or IV, and it is designed to increase blood flow to the myocardium. So once you improve the blood flow to the myocardium, the pain subsides. But once again, if the pain continues after the 3 doses of nitroglycerin, the patient needs to make arrangements by calling 911 and getting to their provider or hospital as soon as possible. Some things to consider with our older population or our geriatric population if they are sensitive to nitrates and calcium channel blockers. So if you have a client who's taken nitroglycerin sublingually at home for their angina, they need to know that whenever they go to stand up, that they need to carefully and slowly. It puts them at risk for a fall because it can drop their blood pressure suddenly, which is known as orthostatic hypotension. So they're just very sensitive to these types of medications. So they need to use these drugs with caution. You need to assess for those orthostatic BP changes that can occur. So we need to make sure that we educate the patient of their potential fall risk when using nitrates and calcium channel blockers. So now we're going to move on to MI, also known as a myocardial infarction or a heart attack. And this occurs when there is a prolonged total occlusion of coronary arterial blood flow. So we have two types of MI. The first is called an ST elevation MI, known as a STEMI. The STEMI you may hear in the hospital, you may hear that term. And it is an infarct that extends through the full thickness of the myocardial wall. The next one is a non-STEMI, or a non-ST elevation MI, and that is a partial thickness MI. It does not extend through the full thickness of the myocardial wall. Now, an MI, whether it's a STEMI or a non-STEMI, can affect the anterior part of the heart, the lateral part of the heart, the inferior part of the heart, or the posterior part of the heart. You can have an acute MI, which means that the MI is brand new. It is brand new onset. It is acute. You can have what's called an evolving MI, which means that the client comes into the hospital, they are currently having their MI. While you are treating them, giving them the appropriate treatment, the MI is getting worse. So it is evolving. And you also have an old MI, which means that the patient had an MI last month or last year. You have an old MI. So time, when we talk about time, that could be what we're talking about when we discuss time as acute, evolving, or old. Now, some of your causes is a thrombus secondary to arterial and atherosclerotic changes or arterial spasms. MI risk factors, and you must know these risk factors. You have to know them. Stress, hypertension, atherosclerosis, CAD, obesity, elevated LDL, which is your low density lipoprotein, which is your bad cholesterol, is elevated. Smoking, physical inactivity, and impaired glucose tolerance, which means diabetes. You need to know the risk factors for MI. So when we talk about ST segment, we're looking at the ST segment that's located on the EKG. On the left diagram, the very top, the very first diagram you see is a normal ECG. You see that the ST segment there is a normal level. The second picture is called ST elevation. You see that the ST segment is way above the normal line. It's called an isometrical line. It's way above the line. That is your ST elevation. That is your STEMI. The next one is a non-STEMI. So you see the ST segment drops down. It loops down. It's below that imaginary line. That is your ST depression. That is your non-STEMI. And then the next one is a T inversion, which is also a non-STEMI. The T wave falls below the isometric line. So for further, if you have a STEMI versus a non-STEMI, if you have a patient come in with a STEMI, that's an ST elevation, that patient has to go to the cath lab immediately. That is protocol just about at every facility. An ST elevated MI, known as a STEMI, has to go to the cath lab immediately. Your non-STEMI is treated with medication, and the patient's monitored for any progression that could occur. But always know that the ST elevated, the STEMI, goes to the cath lab. Now here there is a link on this PowerPoint for you to click on, and it's ECG for Beginners, diagnosis of ST elevation in an MI, your STEMI. So the once again, the ST elevation occurs above the isometric line. That is your STEMI. Anything that falls below that isometric line is your non-STEMI. So here are your MI complications, and you need to know them for your test, and we're going to build on these complications. Know that dysrhythmia and arrhythmia are two terms that we use interchangeably. Dysrhythmia is caused by oxygen deprivation to the myocardium, and as you see, more than 50% of deaths from an MI occur within 72 hours for this reason. Now, this happens because the affected areas are electrically unstable due to shifting electrolytes and oxygen deprivation, as well as the accumulation of lactic acid. And this affects the depolarization and repolarization of those myocardial cells. So those myocardial cells aren't getting the messages they need to receive to squeeze the heart, to squeeze the heart, to squeeze the heart to make the pump. So it's getting lost because the repolarization and depolarization is not getting there. It's not getting there. There's oxygen deprivation and that electrolyte shifts. So the heart's not getting the message to beat like it should. So that's what's happening. Your cardiogenic shock, you have a really high mortality rate with that. And this occurs when more than 40% of the left ventricle has lost its ability to pump effectively. So think about the size of the heart, your left ventricle, how big that is. Now, if you lose 40% of that ability of that left ventricle to pump, you're not pumping out much blood, are you? You're not making a whole lot of circulation. So that cardiogenic shock can set in. You can have a ventricular rupture. You can have a hemopericardium, which is blood in the pericardial sac area, and that results in that cardiac tamponade. The surgeon or the doctor is going to have to insert a needle in that pericardial sac and relieve that blood. You can have a ventricular aneurysm. You can have arterial embolisms. You can have venous thrombus, pulmonary embolisms. So the embolisms and the thrombus, it takes time for those blood clots to occur. But if the blood clot is present and it breaks loose from that extremity or it breaks loose from that lung, it can get up to the heart and cause some devastation there, cause that MI complication to occur. Pericarditis, which is an infection in that pericardium. So if that pericardium has an infected fluid in there, it can't pump effectively. Then again, we also have that mitral insufficiency and mitral regurgitation. These are all MI complications. Yes, you need to know them. So your assessment findings, what is your patient going to look like who is in the process of having an MI? Men, women, and the elderly all present differently. Men typically experience sudden severe chest pain, usually substernal, and it may radiate to the shoulder, arm, teeth, jaw, or throat. Women and the elderly, on the other hand, have very vague symptoms. We have unexplained fatigue, abdominal pain, shortness of breath, and the reason why we're at higher risk is because it's so hard to diagnose us with an MI. So we women, our symptoms are so vague, we're at higher risk for complications because we're harder to diagnose because our symptoms are so vague. Unlike angina pain, rest and nitroglycerin really don't relieve it. However, you are going to try nitro because you don't know if it's angina or if it's an MI. So you want to try to get that patient some relief. So you're going to give them some nitrate to improve that oxygen flow to the myocardium. So you're going to try that even though it may not relieve it. Here there is a link to a video with an emergency cardioversion the patient has, so you may want to check that out. It's pretty interesting. Also know that nausea, tachycardia, and diaphoresis is very typical with an MI, especially in your male clients. You may see those type of symptoms as well. So to diagnose an MI, we look at some serum blood work. First of all, we're going to look at the troponin 1 and the troponin T. A troponin 1, anything greater than 0.035 is pretty much indicative of an MI. With your troponin T, anything greater than 0.1 is going to be indicative of an MI. And that's kind of your gold standard for determining an MI. Your myoglobin is an early marker to cardiac or skeletal injury, so your myoglobin can be elevated because of an injury due to surgery or due to an accident of some sort where you had some sort of injury. That can increase your myoglobin level. So your myoglobin normally should be between 5 and 70, so anything above 70 could be considered a marker for an MI. You also have EKG changes, so you're going to look for that ST elevation above the isometric line. That's going to be indicative of an MI. So these are your diagnostics for your MI. There is a link to a video here on having a heart attack. Please take a look at that video as you go through your PowerPoint slides. Thank you. So treating an MI, time is muscle. The longer it takes you to treat an MI, the more muscle you lose. So treatment is directed towards reducing tissue hypoxia, relieving pain, treating shock if present, and alleviating those dysrhythmias. So those dysrhythmias during an MI is the primary, like I said, effect of the depolarization and repolarization of myocardial cells. So that's not occurring. So that's why you're having those dysrhythmias. So we want to get that under control. So we're going to relieve that hypoxia by giving our patient some oxygen. We're going to relieve that pain by giving them some morphine. Know that morphine not only decreases the pain perception and anxiety, but it also helps to decrease the heart rate. It slows the patient's heart rate down. It lowers their blood pressure, and it decreases that demand for oxygen, so that morphine helps that patient relax. We can also give them an antiplatelet like aspirin. We're going to give them a baby aspirin to chew up. We could treat them with some Plavix. So the purpose of those antiplatelets, or the aspirin especially, is to prevent blood from clotting. Aspirin is used to prevent blood clot formation by reducing the platelet aggregation. Therefore, the nurse should instruct the client that the aspirin is prescribed for their coronary artery disease to prevent MI or prevent those clots from forming as a result of an MI. So that's why we're going to give them that aspirin. So we need to tell them that that's why they're taking it. If you're going to give that patient some anticoagulants such as Coumadin, remember you've got to monitor that INR level, right? So monitor that INR level closely. Thrombolytic agents, they dissolve those fresh clots that are formed. Lots of times that's called TPA or streptokinase. We're going to give those beta blockers. Remember, that decreases the myocardial oxygen demand by reducing the heart rate and that workload of the heart. So that's why we're going to give those beta blockers. We're going to give that heparin and Coumadin to prevent any further clot formation from developing. So that's when you have to monitor those serum lab values. So make sure that whenever you're giving medications that you know as a nurse what you're going to have to monitor and look for. So with your anticoagulants, your patient may have a tendency to bleed, so you're going to monitor them for some bleeding. With those beta blockers, they may drop their blood pressure. It may get too low. Their heart rate may slow down too much. So as a nurse, you're going to have to monitor those things. So make sure that you understand as a nurse what you're going to monitor when you give these medications. So surgical management consists of a CABG, which is your coronary artery bypass graft, or a stent placement, or PTCA, or a cardiomyoplasty. You may have to encourage the patient to do some cardiac rehabilitation. Now, the cardiac rehabilitation, the goal of that program is to extend and improve the quality of life. So that's why you want a patient to get involved in cardiac rehab. You want to extend and improve their quality of life. And that is a medically supervised program, and it combines education and exercise, and usually a nurse monitors the patients whenever they come in and have that done. Once again, there's a link here on this particular slide with emergency room treatment of heart attack symptoms when the patient comes in. So take a few minutes and watch that video. Now, nursing management, let's start with nursing management after they've had a cardiac procedure, such as a CABG or a PTCA. So you're going to monitor those sites. Say they have a CABG done. You're going to look at that chest incision. If they've had a PTCA done, you're going to look at those injectable sites, which is their femoral arteries, their radial arteries, their brachial arteries, wherever they put that catheter through. You have to monitor those sites. You're going to monitor the patient's urine output, because remember, they can have kidney injury that can happen as a result of that decreased nourishment and oxygen flow to those vital organs. So monitor that patient for any acute renal failure that can occur. So look at those sites, especially your PTCA sites, and you're going to monitor for any type of hematoma that can occur. So say your patient is taking a heparin drip is infusing prior to their procedure. Well, you're going to make sure you check the chart for an order to stop that heparin prior to the procedure. Heparin has a short half-life, so it doesn't maintain in the system very long. So you can turn it off pretty much before they go for their procedure, and you'll be okay. Now, failure to hold a medication or turn that heparin off before they have the procedure can result in the patient bleeding out. It can develop some hematomas, and they can actually bleed out during their procedure. So be very mindful to check your orders and check your chart about any type of holding or stopping a medication before a patient has a procedure. When the patient comes back, like I said, you're going to look at those incisional sites, you're going to look at those puncture sites, look for any signs of hematoma, and make sure you are monitoring those pulses. Say a patient has a cardiac cath in the left femoral artery, you're going to check that left pedal pulse every 15 minutes, and you're going to compare it to the right pedal pulse. And then you're going to look at that left femoral puncture site for signs of hematoma, because a patient can actually bleed out and form a hematoma that can run down the length of their thigh to their knee, and it can run up into their abdomen. It can get over to as far over as to their belly button. That hematoma can grow. It can become massive. It's just not going to stay in one localized area. So you have to monitor that patient closely for that hematoma formation, and just make sure that you are checking their vital signs pretty frequently after that surgical procedure. So whenever you do their initial assessment, you're going to get that pain description, those vital signs. You're going to look at their cardiac rhythm, see what that rhythm is. Listen to those heart sounds, listen to those lung sounds, and check those peripheral pulses and compare them bilaterally. Like I said, monitor for signs of bleeding if thrombolytic agents are being used. Uh, Administer medication. Make sure that you are giving them that oxygen. Like I said, we always try nitroglycerin first because you don't know if it's an MI or if it's angina. Sometimes you don't know, so you want to go ahead and try that nitroglycerin first to try to open up that flow to the myocardium. And we're going to give them some morphine if the nitroglycerin doesn't work. So MONA is the acronym we used, morphine, oxygen, nitro, and we're going to give them a baby aspirin to chew up as well. So know that that patient's going to be fearful, especially if they are having a really severe heart attack. It's not unusual for have those patients be very fearful. They will have that impending doom. Once you ever see that on a patient, that impending doom, you never forget what that looks like, and you will always know it every time you see it. Know that you're going to promote some rest, explain all those procedures, acknowledge grief. When someone has an MI, especially a massive MI, when someone has an MI, that's a life altering event. So they may not perceive their life going on as normal whenever they leave the hospital. They may have to change how they do some things whenever they leave, especially if they're on some type of anticoagulant therapy afterwards. And be sure to prescribe any of those sedatives that they may need, just to help decrease that anxiety. And of course, encourage that cardiac rehab. So our nursing management for the MI, procedure, pre-MI, during the procedure, follow-up care is pretty extensive for the nurse. So just be aware of all those things that nurses have to do for that care of the MI. So here's a side-by-side comparison with angina and MI. So here I have stable angina, and that's related to exertion or stress, and it's relieved with rest or nitroglycerin. And the pain usually lasts about 15 minutes, so that would be 3 rounds of nitroglycerin sublingual. These clients do not have nausea, they don't have epigastric distress, they don't have any shortness of breath, they're not really anxious, and they're not diaphoretic. Whereas your MI client is going to have pain that starts early in the morning, especially after they've rested all night. The pain's relieved by opioids such as morphine. Now we're going to try nitroglycerin and rest when the client first comes into the ER or they're on the floor at the hospital. We're going to give them some nitroglycerin because we do not have the result of their lab work back, and the EKG tech hasn't come to do the EKG yet. So we're going to go by their signs and symptoms and give them some nitroglycerin. But this pain is going to last longer than 20 minutes, and it's not going to be relieved by anything but your morphine. These clients will have nausea. They are going to be short of breath. They are going to be very anxious because they have that impending doom feeling. And they're going to be diaphoretic as well. So just know the difference between your MI pain and your angina pain. So how do we get clients who are outside of the hospital to survive an MI? So recognition of a cardiac arrest and activation of your emergency response system is key. If you're someplace that has an AED, you need to know where to get it and know how to use it. Start CPR immediately. Get that AED on next. Defibrillate that client. Call for your backup. Have your EMS en route, and always call for help to get someone to make the phone calls for you. But this is your 5 links to the adult out of hospital chain of survival. So now we're going to talk about occlusive disorders of peripheral blood vessels. So this is your peripheral vascular disease known as PVD. This is a condition that affects primarily the blood vessels that supply oxygen to our lower extremities. Examples of this are your PAD, your Raynaud's disease, thrombosis, phlebothrombosis, and embolism. Men are affected more than women with PAD in the lower extremities. Complications can be critical limb ischemia, characterized by open sores or infections that do not resolve. These become gangrenous and threaten the viability of the limb and the result in amputation. So your Raynaud's disease is brief spasms of the arteries or arterioles in the fingers, toes, nose, ears, chins, and they cause temporary ischemia to the tissues. The vessels dilate widely to compensate for the restriction. You have patchy areas of necrosis that can occur with prolonged ischemia. Your assessment findings: numbness and tingling, awkwardness, fumbling after the initial pallor. The hands, especially the fingers, become deeply cyanotic and begin to ache. You have ischemia, pain, and paresthesia. The hallmark sign of Raynaud's is pain related to arterial insufficiency. Pallor is the initial symptom in Raynaud's, followed by cyanosis and the aching pain. Diagnostics is based on history of symptoms and examination. Our medical management consists of avoiding factors that precipitate attacks. Smoking cessation is imperative. Drug therapy with peripheral vasodilators can also aid in the management of Raynaud's. Surgical management, if ischemia occurs for a prolonged period of time, gangrenous areas may have to be amputated. So, as nurses, we need to educate both the client and the patient about their disease process and how important it is to for them to understand factors or things that contribute to an attack. So, make sure that you instruct the client as well as their family to avoid situations that contribute to the ischemic episodes. We can warm the hands in some water to stop an attack. We can teach the client imagery that can be used to help divert their thoughts and their feelings away from that pain that's occurring in their hands. Wearing gloves during household chores or whenever they go out, like to the grocery store or something like that, they might help them as well. So we educate both the family and the client about their Raynaud's. Thrombus, phlebothrombosis, and embolism. Please know the difference between the three. A thrombus is the formation or presence of a thrombus, a clotting within a blood vessel that may cause infarction of tissue supplied by the vessel. Phlebothrombosis is a thrombus or clotting in a vein without primary inflammation. And then your embolism is an obstruction or occlusion of a vessel by an embolus. So you want to make sure that when you are doing your nursing assessment that you're looking at the skin color, the temperature, the capillary refill, and the tissue integrity. So what are our assessment findings and diagnostics for thrombosis, phlebothrombosis, and the embolism. Well, you're going to have numbness, tingling, cramping, arterial pulsations absent below the obstructed area. That's going to be your assessment finding. Your diagnostics, you're going to do arteriography, venography, Dopplers. You're going to do those bilateral Doppler studies, ultrasounds. Those are the most common things that you're going to see as far as your diagnostics. If you have a client who's got a deep vein thrombosis, they may have a mild fever and pain, swelling, tenderness in the affected extremity, and even a positive Holman sign. So, our medical and surgical management for thrombosis, phlebothrombosis, and embolism. Our medical management is going to be bed rest, elevation of the extremity, maybe some subcutaneous or continuous IV heparin therapy. In that case, you're going to monitor the PTTs for that. Surgically, they may put in a filter, vena cava filter, to keep the clots from traveling and moving to other areas of the body. You can do a thrombectomy or an endarterectomy, and a lot just depends on whether it's an artery or a vein that's occluded and the degree of occlusion. So make sure that you understand how to calculate a heparin drip. I have 2 links in Blackboard for heparin drip formulas and calculations so that you can go in and practice heparin drip calculation. From a nursing standpoint, history of symptoms, characteristics of pain, presence of a Holman sign, what the extremities look like, comparison of skin color, temperature, capillary refill, tissue integrity. Do you need to measure the calf or the extremity of the arm? You need to palpate those peripheral pulses and compare them bilaterally. A client who has one of these, whether it's a thrombus, phlebothrombosis, or an embolism, shortness of breath that comes on suddenly, as well as chest pain, indicates that the embolus has moved to the lungs. In that case, it's then a pulmonary embolism, and that can become a critical situation, so you need to notify the physician immediately when your patient starts to develop these sudden onset of signs. So, our venous insufficiency is when there is inadequate drainage of venous blood from a part, resulting in edema, dermatosis. Most often, it's seen in veins in the lower extremities. Sometimes it's secondary to varicose veins or valvular damage from thrombosis. So, with venous insufficiency, if you're doing your assessment, you may find that the client's feet or foot is swollen. You're going to see some stasis dermatitis and even some stasis ulcer formation whenever you do the assessment on the extremities. So, diagnostics is done by Doppler or ultrasound. Medical management consists of Job stockings, also known as TAD hose. We can use pneumatic compression devices, which are your pneumatic pumps, but sometimes surgery may be necessary, and that would be a vascular surgeon involved in that. The major goal in management of venous insufficiency is to promote venous circulation. So that's why we want to put those Job stockings on to promote that circulation. From a nursing standpoint, you're going to assess the appearance and quality of circulation. So you're going to check those pulses, look at that skin, do a really good assessment of those lower extremities. elevate the legs, apply those compression devices or stockings, and instruct that client not to cross their legs. So, a varicose vein is caused when valves in the vein become incompetent, and that results in varicosities. This can be caused by prolonged standing, obesity, pregnancy, um, liver or abdominal tumors. Your assessment findings: the client's legs may feel heavy and tight, particularly after prolonged standing. Activity or elevation of the legs relieves the discomfort. Leg veins look distended and tortuous, and they can be seen under the skin as dark blue or purple. And they can even be snake like elevations, as noted in the picture on the left. Diagnostics are going to be the Brody's Trendelenburg test. Our medical management consists of encouraging the client to exercise, lose weight, wear compression hose or socks, avoid prolonged periods of sitting or standing. Surgical management may be needed, so we may do a vein litigation, vein stripping, sclerotherapy, radiofrequency therapy to treat those varicose veins. From our nursing standpoint, you're going to assess the skin, look at the distal circulation, peripheral edema, the client's level of discomfort, the ability to do active or isometric leg exercises. You're going to encourage them to ambulate post surgically, and of course, wear those anti embolism stockings. So, an aneurysm is the stretching and bulging of an arterial wall. So, if you think about blood flowing through an artery each time the heart beats, the pressure it puts, and how that would stretch and cause a bulge in the artery wall. So, the causes can be arteriosclerosis, hypertension, trauma, or a congenital weakness. So our assessment findings depends on the location of the aneurysm. So most of the time, as with an aneurysm, a patient can be asymptomatic. But as the aneurysm grows and becomes bigger, they can develop pain and discomfort. And like I said, symptoms will be related to pressure on nearby structures, so it's going to depend on the location of an aneurysm. For an abdominal aneurysm, abdominal aortic aneurysm, which is your AAA, it is a constant gnawing pain located in the abdominal area as well as the flank and back area, and the pain is very severe. You may even see a pulsating mass at the abdominal area, and you can hear a bruit with your stethoscope. The patient will also have an elevated blood pressure. With your thoracic aortic aneurysm, they're going to have severe back pain. Depending on how large it is, they can have hoarseness, cough, shortness of breath, difficulty swallowing, and decreased urinary output if it's a thoracic aortic aneurysm. With an aortic dissection, this is when the aneurysm is starting to evolve and get larger quickly. You see this lots of times with your Marfan's patients, but not always. It is a sudden onset. You have a tearing, ripping, or stabbing, abdominal pain, and hypovolemic shock. I have seen aortic dissection before, and it was quite messy. There was a lot of blood involved in that. They will have that hypovolemic shock, which is a low blood pressure and elevated heart rate, as well as decreased cardiac output as that result. Diagnostics is done lots of times with a simple CT scan or MRI. They can also do an aorticography, and that will determine the size and location of the aneurysm. Medical management is going to be administering those antihypertensive drugs. So you want to keep that blood pressure within range. You don't want it to be very high. They can also do surgical management. They may have to bypass or replace the area that's bulged by doing some type of surgery, especially if it gets to a certain size and depending on location. Our nursing responsibilities for an aneurysm is to keep stress and activity to a minimum. You want to teach the patient to avoid straining during BMs and coughing. You don't want them to hold their breath while changing their position, because that can, this straining and coughing can just put pressure on the aneurysm. Monitor their vital signs, their eyes and nose. Do a good skin assessment, color, temperature. Look for that pulsating mass at the abdomen. Post op, if they have to have surgery post operatively, you're going to monitor that level of consciousness, characteristic and location of any of the pain that they may complain of, signs of any hemorrhage or dissection that can occur after surgery, and know that all aneurysms can be life threatening. This concludes the lecture for Chapter 25. If you have any questions, please feel free to email or text me. And know, follow your heart, but take your brain with you. Have a great day.